All right, everybody. I'm thankful to be able to speak to you today for your conference. My name is Dr. Brandon Barton. I am a physician that specializes in movement disorders. I practice out of Chicago, and I work part-time at the Jesse Brown VA Medical Center, where I have most of my appointment at this point serving the veterans and with movement disorders and Parkinson's and related disorders. And I'm also at Rush University, where I've been for the last 16 years as an associate professor there, where I serve in the section of movement disorders. I've had a lot of clinical experience with patients with Parkinsonian disorders and multiple system atrophy, and I just wanted to give an overview today to complement the other lectures on how to treat the symptoms of MSA. And the learning objectives are to recite the medical treatment options for patients with MSA and to figure out how to decide between treatments that are optimally individualized for each patient. And then also think about the non-pharmaceutical based treatments and lifestyle changes that apply to multiple system atrophy. And of note, I am leaving aside the treatment of dysautonomia, which is, I'm told, is covered in other lectures in depth. So I'm going to be talking about many of the other features just to give a sort of broad overview of the multiple drugs and therapies that are available to treat the symptoms. And I'd start off with this slide to show that recommending a medication therapy is more complicated than ever for several reasons. First is that there's a greater diversity of drug formulations than ever in history, even just for Parkinson's or Parkinsonism alone. Now there's one or two more per year for the last several years. And so the question always comes up, which is the best one to use? You're going to have different opinions on that depending on which specialist you ask. And I'm going to have a different opinion based year to year on what I've tried and what successes I've had and what patients I've seen. So this is an ever ongoing evolution of recommendations. We have more and more studies and data, not as much for MSA as for Parkinson's, but the Parkinson's studies can be extrapolated to those people with MSA. We have more patient preferences nowadays with direct marketing and changes in the doctor-patient relationship and more interest in alternative therapies that guide our decisions. It's never, I think, a paternalistic model, as we call it, the old model where the patient comes to the doctor and the doctor, as a father-like figure, says, "Oh, this is what you should do," and the patient doesn't ask questions and walks away and does it. That I think that model's kind of gone for the most part now. People want to be empowered and to know what to do, and they're going to have read things online. They're going to have Googled and AI to things now, and we have to work with their preferences. We have to think about cost as well, because drugs are more expensive than ever, and fortunately, a lot of the classic drugs are still cheap and old. We're also more aware and cognizant of the side effects of medications, especially the non-motor side effects, which are very prominent in MSA. So we have to keep those in mind. And then we also know a lot more about exercise and how that improves and treats your outcomes with MSA and other Parkinsonian disorders. And so we're going to recommend that more, at least in conjunction with the medications. So all of these factors make it more difficult, but also rewarding to find the right treatment for each patient because there's so many options now, which is the nice thing. So we don't really know what works for everybody in MSA. There's no one drug that seems to work well for everybody, and I think that reflects the fact that the patients are so different. MSA is notoriously a broad range disorder, a heterogeneous collection of symptoms, and no two people are going to be quite exactly the same. And so there's not really a trial or a treatment that says this is the main drug to try for everybody. It's a little bit of finding your own best treatment. But when we think of treatment, we go back to the basis of what we understand about the disease. What's the pathology? What's the biochemistry? What are the symptoms? What's the progression of the disease? And we make our decisions based on those things. This is just the brief overview. You'll get more on pathology in other lectures, but this is just to show that top slide here shows the different areas in blue in the deep brain where you find the problem in MSA, which is a collection of alpha-synuclein, which is a protein that abnormally clumps together in the supportive brain cells or the glia. and causes anatomical changes and chemical changes in those areas, and therefore leads to the symptoms of MSA. You have the most critically the substantia nigra, which is this little strip right here that on the top second diagram on the left, which shows where the dopamine is being produced. There's some abnormalities there, and then you have accumulation in the basal ganglia, which is the deep gray matter, where there's some damage to those cells as well. In addition to some of the memory circuits, the entorhinal cortex, as well as the cerebellum on the right, which is the area which causes the symptoms of ataxia. So when we look at any given patient, they're going to have some collection of findings of pathology of alpha-synuclein across all these areas here. And ultimately, the damage that's done leads to some loss of production of dopamine in the substantia nigra. And injury to the cerebellum leads to the symptoms of ataxia. And we know that the main two clinical forms of MSA are Parkinsonism and ataxia. My patients are broadly lumped into those two categories. And so it's due to the pathology accumulating in these areas. And just of note, the Parkinsonian symptoms begin when about 60% of the dopamine producing cells are gone. So you have to lose quite a bit of them in order to start to show the symptoms. And the diagram on the left, on the bottom left, is a picture of the synuclein that's stained in the brain cells that you can just see visually when you look at the brain tissue. And so what happens when you damage that substantia nigra? Well, then you lose the projections, as you see these red lines here that go up to the to what's called the striatum, which is the deeper part of the brain, the caudate nucleus and the putamen, which is where the dopamine receptors are. And then that leads you to have less dopamine activation and more symptoms related to Parkinson's disease. And you can measure the image. There's an image you can use to measure the damage to these areas. It's called the DAT scan, which I don't have pictured here, but the DAT scan would kind of confirm that you have loss of dopamine production in this area. And often that's a confirmatory test to prove that you have MSA versus another disorder. So the treatments, the general treatment goals we have are, number one, to slow the degenerative process and therefore keep you in the milder stages longer. A perfect treatment would freeze the disease right where it's at and allow you not to get any progression and just deal with the mild symptoms you have at the beginning. And then if we can't do that, well, we have to replace the depleted neurotransmitters. Most of the medications we have do just that. We can replace all of the transmitters that are lost in the brain injury related to MSA. Do they work or not? That's the question. In MSA, the drugs and the transmitter replacement does not work as well as compared to Parkinson's disease. But we still try them and they do work in many cases. And then there's non-pharmacological treatment, which I'll talk about too. And I'll skip over this slide because it didn't come up well. But the categories for treatments are, again, neuroprotection and symptomatic. And when we think of symptomatic treatment, we think of monotherapy, which is just one drug, or adjunct therapy, which means combining multiple drugs together, or drugs that treat the side effects of the drugs we're using, which occurs in more advanced MSA, where you, for example, you need to give levodopa, but it causes low blood pressure and it causes dyskinesia, and therefore we have to give drugs for low blood pressure and dyskinesia, and you have to combine drugs together to get the best outcomes. And let me tell you that in neuroprotection, meaning a drug that would block the disease from progressing, which is our goal in the research world. We do not have an established intervention here. There are studies going on. There are many studies that have failed in the past. I listed some of them there: minocycline, rifampin, rasagiline, fluoxetine, verdiperstat, if I'm saying that right, lithium, and polyphenols. They all are drugs that have been tried in different trials, controlled versus placebo, and have not worked. There are many drugs under investigation, which you'll hear from other talks about, drugs that block that alpha-synuclein protein from accumulating, and then antibodies that might clear it out from the body once it's been there. But as of now, we don't have a good neuroprotective agent. And why is it so hard to find a neuroprotective treatment? Well, first of all, the disease is not well understood, right? We don't have the full comprehension of what we're trying to block, and so we're just throwing things at it and hoping that it works and seeing if it does or not. And when you give a drug to a patient with a neurologic disease, you have to account for something called the placebo effect, which means that if you're taking a drug and you feel like that you're feeling a little better, you're a little optimistic, you might get a little more active, you might feel a little more hopeful, you might have less symptoms, you might have some hope, and then all of those things may just be based on the placebo, meaning you're just doing something good for yourself, you're being hopeful, you're having faith, and those things all do make you better. But does the actual drug that you're getting make you better in addition to that? That's the question. That you don't know until you compare the two groups of people, one that gets the drug and one that doesn't get the drug. Both of them are hopeful that they're on the drug, and so they both get that placebo effect. But which group is going to get better than the other, we don't know. So that's why you have to do what we call double-blind, placebo-controlled trials, where you give the chance of blinding, where not even the doctors or the patients know what they're on, a chance to see if it really works. And just a general thing is, if you look at a trial and it says it's hopeful for working in MSA, you want to first look to see, was it an open label trial or was it a blinded trial? Because if it's open label, that means that there was no placebo and that everybody knew they were on the drug. So that means that potentially the placebo effect is at play there. But in general, people often do open label in small numbers of people, or when there's not enough money to do a randomized trial, just to get a sense first if the drug has a little effect that justifies doing the grants or getting the money or going forward with it. So if it's open label, it's a little less potent of a recommendation. Also, when you look at a study, I always tell people, make sure you see that it's in humans too, because a lot of the study trials that are reported on the news or in small studies, they're not quite in humans, they're in mice or they're in cells, things like that. There's a natural progression of research that's relatively slow, but it takes things from the lower level to the higher level of complexity and cost. And the other point is that it takes 1 to 2 years to do a study on a disease, and that's not including the time that it takes to wrap up the study and the time to start the study, which could take overall 5 or 10 years. But patients are usually in the study for 1 or 2 years, and that's about as long as you can do before complications occur or it gets too hard to monitor all the different directions the patients go. So it's and the diseases we're dealing with are very long in development, and so is 1 or 2 years long enough to see the result or not? We don't know. We don't really have perfect biomarkers, although those are in development, to see if we can measure those and see if the progress slows down or not. And then we just have limited trial designs as well, which don't help us to interpret the outcomes as well. There's no accepted biomarker for protection. All we can see is whether or not one group got better than another. I'm going to skip over this slide. So the treatment interventions that have evidence, for the most part, are listed here, and these are somewhat extrapolated from the drugs for Parkinson's disease. There's 5 major categories that we could try in MSA that work in Parkinson's disease and that might work in MSA as well. The main categories, we'll go through each one: levodopa, MAO-B inhibitors, dopamine agonists, amantadine, and anticholinergic drugs. These are the distinct classes here. And I recommend not following any one specific treatment algorithm because, again, everybody's so different from one another. And however, if you look out there, you'll see a lot of patients' algorithms where they say, if start with this drug, if that doesn't work, use that drug, for example. But none are universally adopted, and there's many differences between the different algorithms. So we can't really, each patient has to start with a recommended treatment based on their own symptoms. And you also have to keep in mind that you have many non-motor symptoms. So when you have MSA, you have the motor symptoms, which is what usually brings the patient in, the difficulty moving, speaking, falls, things like that, or tremors. But then when you start looking under the surface of the top of the iceberg, as pictured here, you see that there's a lot of other symptoms, and that's due to the fact that there's widespread involvement of the alpha-synuclein throughout the nervous system that causes multiple problems in most neurological domains. And so you have to do a comprehensive survey looking through which symptoms are more prevalent than others and finding the ones that are the most bothersome to that one patient and find the best treatment. that applies to that one person. And keep in mind that when you're treating the tremor and the walking, for example, you might accidentally worsen some of the other non-motor symptoms. The classic example would be, you have somebody that comes in with low blood pressure, you give them amantadine for their tremor, and the blood pressure goes even lower. So you have to balance the motor and the non-motor treatments. And this is a not comprehensive but fairly uh, detailed list of non-motor symptoms that could occur with Parkinsonian disorders, both Parkinson's and MSA. As you can see, they're grouped into major categories of neuropsychiatric, which means mood and behavior and cognitive issues, the sleep, which is a very big problem, sometimes a fatal problem in MSA. There's autonomic dysfunction, which is one of the defining features of MSA. And then there's sensory symptoms, which are underappreciated, but a big part of it as well, such as pain, smell and vision issues. And then there's just other things as well that are miscellaneous, like fatigue, weight loss, skin changes, greasy skin, or respiratory complaints. So each of these things need to be really screened for. It could take a while, as you can see, to go through each of these because each patient might have 5 or 10 at least of these things in their syndrome, and each one has an individual treatment and an individual plan you have to make. And the treatment menu is pictured here. That I like to think about the interaction between the doctor and the patient is less the paternalistic model and more of like the guide model, where you show the patient all the different options, you make them aware of what's available, and then you decide together which one seems to be the best. And I take into account the patient preferences, my preferences, the other diseases they have, what stage of the disease they're at, their age, their other non-motor symptoms, and then just general cost and availability of the drugs where they're at, or based on their insurance. Unfortunately, we have to think about. If you take all those things to account, you just start making decisions, and you see, if something works well, if it tastes good, with the analogy of the menu, then you keep it. If you don't like it, you can send it back and try something else. And there's a very large, ever expanding menu of drugs and treatments here. And that being said, you also have to treat the right syndrome as well, because in MSA, the drugs have to match the syndrome. Everybody's a little bit different. And the major categories that you can use to apply your drugs to are listed here. There's Parkinsonism, which is the most common demonstration that we see, and that most of the drugs are here because of Parkinson's and the pipeline for Parkinson's. Most of the drugs that you'll find are in this category to help the dopamine stimulation. But there's also ataxia, which is the balance and coordination issues, the dysautonomia, the dystonia, which is a muscle contraction disorder. There's the throat issues like dysphagia, which means swallowing problems, and bulbar symptoms, which means problems controlling the lower throat and face. Spasticity, which is excessive stiffness of the muscles, sleep issues, and pain and musculoskeletal issues. I'm going to go through each of these a little bit here. The first drug I'd mention is the one that we're going to be using the most often in MSA. It's called levodopa, and it's a prodrug of dopamine, which gets into the brain. It crosses the blood-brain barrier and turns into dopamine. It replaces that lost dopamine that you get from the substantia nigra damage, and it stimulates the brain probably more than any other drug for Parkinsonism. It's been out for, it should be 5 decades. Yeah, it's been out for 5 decades or more, and it's cheap, it's available. There are 3 main forms used now. There's the standard instant release formulation, which is Symptomatic, the older controlled release, which is Symptomatic CR, and then there's 2 new ones in the US, which are called Rytary and Crexont, and those are just longer extended release forms. They're all carbidopa levodopa, but they all have different half-lives, or the amount of time they last in the bloodstream. Usually we just use the instant release or the Symptomatic for MSA because we need the most effective drug up front. It's relatively easy to start. It's cheaper. You can do higher doses relatively quickly. You can use the newer formulations if you are wearing off too soon, or the older formulations aren't working well, but usually we don't have to do that in an MSA. But just to know they're available. Occasionally a patient will tolerate the newer ones better than the older ones based just on their metabolism. And I will try the newer ones in some patients. The side effects of the levodopa are typically relatively more mild compared to the other drugs. They're the general dopamine side effects, which are nausea, vomiting, dizziness, impulsiveness, hallucinations, or hypotension, the low blood pressure. So you have to keep all those in mind when you give it. The higher of dose you give, the more you'll have of those side effects. And is levodopa the most preferred to use? Well, even in Parkinson's world, we're starting to say that this is really the best drug to use, and that all the other drugs are more peripheral because it causes better quality of life, better early efficacy for drug treatment than compared to the other ones. In MSA, it's a statistic that only about 2/3 or 65% of patients can respond well to levodopa initially, and then it's the effect sort of fades off or it causes too many side effects after a few years, as opposed to Parkinson's, where the drug effect is still good five to 10 years later. But in most patients, it's well advised to be on at least a little carbidopa levodopa, because if they have a little stimulation, it's better than nothing. And a lot of times you try to get rid of the levodopa and they get worse, even if it's just a low dose. So most of my patients with any Parkinsonism are going to be on at least a low dose levodopa. And we'll try higher dose at some point, but if it's not worth it, we won't keep it at the high dose. What's a high dose? Well, it's 1,000 milligrams daily of the instant release is about they consider the high dose of carbidopa levodopa, but some people can go higher than that, maybe even 1,500, rarely 2,000, something like that. Another feature of MSA is that when you give too much carbidopa levodopa, you could get stimulation of the lower face and get overactive muscles there. It's called orofacial dystonia. There's a picture on the right that's classic in the literature of a patient who's got the lower facial contraction and grimacing and the straining of the neck muscles, and that's due to the overstimulation of the carbidopa levodopa. It's a form of dyskinesia, which is overactivity due to dopamine stimulation. And so sometimes that limits our dose there. Most other drugs that are used for Parkinson's are weaker than carbidopa levodopa and may not cause immediate improvement, which is during the time of the first few years when the drug may work the best. So we don't want to mess around with the weaker drugs at the beginning. We usually just do the levodopa and add the other ones if they seem to make sense. The second most common one we'll use is amantadine, which is a antiviral agent that isn't used as an antiviral anymore because it lacks that proof, but it does have a mixed effect on multiple receptors. There's a dopamine enhancing effect. There's an anticholinergic effect, which is the effect it has on the cholinergic system, which is a separate chemical system from dopamine. And it has an anti-excitatory effect where it blocks something called the NMDA receptors, which is an overstimulating receptor that causes dyskinesia, possibly some ataxia symptoms. If you could block that, you could get some improvement in those symptoms. It's another cheap old drug. It can help with dyskinesia, dystonia, and tremor. It's cleared as an active agent through the kidneys renally, so you have to adjust for your kidney function. Usually you give 100 to 300 milligrams a day. And in Parkinson's, it's shown to be an efficacious drug to be used by itself or as an adjunct to levodopa. The side effects have a little bit more than the typical dopamine drugs. There's possibility of more hallucinations and what we call anticholinergic side effects, which is constipation, dry mouth, dry eyes, urinary retention. Livedo reticularis, which is a lacy red pattern of the skin, which is reversible. Some swelling or some blurry vision or edema in the lids, in the eye covering of the eye, the cornea. So that's a little bit of a risk for the side effects, but in many patients, just a low dose is reasonably helpful. The other drugs that are available, we're not going to use that much of. There's a category called the MAOB inhibitors, which is something that blocks the dopamine from being broken down. There's selegiline, there's rasagiline, and then there's sulfonamide. The sulfonamide is a newer one I haven't really used that much, but the previous two I have used quite a bit just as an add-on. Sometimes there's people that don't tolerate carbidopa levodopa. They don't tolerate the amantadine, and this is sort of the third thing I'll try and say, well, if this is better than nothing, it's relatively weak, but it'll raise your dopamine levels a little bit, and let's try it and see what we can get out of it. And a lot of people can tolerate these, and it helps just a little. So I do try this category often. It's maybe second, third line. The side effects are fairly mild, similar to carbidopa levodopa. The selegiline has a little more insomnia with it because it has an amphetamine-like byproduct. But sometimes we selectively use this drug because the patient's tired and say maybe that'll help them a little bit. In select patients, they can feel a little more energy from selegiline. There is a warning that you'll get with these drugs that just pops up that says if you take it with other antidepressants or other serotonin drugs, that you might get a side effect interaction, but we always override that and say it's generally not a concern based on extensive data monitoring it. We just tell people to watch your symptoms. If you feel worse, don't take it. But just so you know, when you get prescribed one of those drugs, you might get a warning from the pharmacist or your doctor that says it might have some drug interactions. Usually it's safe. The last category, which is maybe the last one I'll use in MSA, is called dopamine agonists. There's many of these drugs out there. The ones most familiar are pramipexole, rotigotine, ropinirole. Some of them have gone away the way of history because they have too many side effects, but these are the main categories here. Apomorphine is a newer one that has an injection form, and for a short time it had a sublingual form, but now it's also got a pump form as well. That one's a potent dopamine drug, but it doesn't have an advantage over carbidopa levodopa, I'd say, compared to the regular levodopa in MSA patients. So the problem with this category of drug is the side effects. It does have some benefit in that it directly stimulates the dopamine receptors. It's probably reasonably effective for milder patients. It doesn't have any requirement to take without food, and it doesn't require any sort of special dietary restrictions. It lasts a little bit longer in the body. I'd say that the downside is that you get more side effects with it, and these are all things that patients with MSA already have: the dizziness, hypotension, somnolence, it's just tiredness, confusion, hallucinations, paranoia, impulse control disorders, which means you can't control your indulgence in pleasurable things. So this class of drugs, based on the side effects and based on the fact that it's weaker than levodopa, we usually don't use it very much. But with all things, if there's a patient that doesn't tolerate anything else, I will use these in low doses, and it might be the one drug they can tolerate. There is one that's a patch form that's called rotigotine that some people tolerate better because it goes through the skin and gets absorbed slowly at a low dose. Some people like that drug. I want to find something that's going to stimulate the dopamine. This is the last choice usually, but if this is the only choice and this is what works, we'll go with it. We have to go with it. I'll skip that slide there. And then the anticholinergics is the last class that I can talk about. It helps the dopamine system, but in an indirect way. It's primarily used for tremor. We might also use it for dystonia too, which is a contraction of the muscles in the body due to brain injury from MSA. But we use it mainly in younger patients because it has more side effects. It has more cognitive issues, more fatigue, constipation, dry mouth, urinary retention, which are all things that MSA patients have. So this is another sort of last resort, but possible to use if you have a lot of tremor or dystonia and you have no other drug that's really going to help it. You can test these out, but usually they're not tolerated, but it's on the table to try. And then there's other treatments out there that you'll read about for Parkinson's that are probably not ever going to be used for MSA substantially, like drugs for wearing off. There's a few categories there, but usually the wearing off is not significant in MSA, and it's better addressed by more dopamine than it is by adding any of these newer add-on drugs. The surgeries are generally recommended against because there's never been too many cases where somebody had a good outcome for surgery for MSA. There's rare exceptions, where somebody has a lot of tremor, for example, and that might go away with one of the surgeries, such as focused ultrasound, which is a focal lesion created by ultrasound heat in the brain. But that would be used sparingly and rarely in patients unless it was the only option, and everybody agreed it was the best thing to do. Rescue treatments are usually not needed in MSA, which are things that you give to give a rapid intake of dopamine, such as the apomorphine shots or inhaled levodopa, because the MSA patients usually don't have severe off periods that need rescue. And there's also a new category of treatment that are pumps, where you could attach the dopamine pump to your side and on the abdomen or on the skin, and it could pump in continuously the drug, which is either apomorphine or phospholevodopa, which is a new form of levodopa. But MSA patients to my knowledge, haven't gotten those drugs yet. It's really more for Parkinson's, more young onset Parkinson's generally. Um, and then dystonia is another syndrome in MSA where you get either a forward neck posture, flexing all the way forward, as pictured on the bottom right, or limb dystonia, such as on the bottom left, where the picture where there's a picture of the toes cramping and curling. That could happen on the fingers too. Or in the upper picture there with the vocal cords, where you get a lot of vocal stiffness in the muscles and spasm of the muscles there. All of these are considered dystonia, and the treatment could be to reposition the dystonic part, such as a neck collar or a splint. If that doesn't work, you can do more PT and OT and speech therapy. The standard treatment is to do some botulinum toxin, which is a focal muscle relaxer that you can inject into the body, that in the part that's overactive, and you can get some reset of the muscle tone where it relaxes a little bit. And the trick is that when you inject it too much in the neck, it might cause some neck weakness or some speaking or swallowing problems, and you can't do that too much in MSA because they already have those problems. But I do have some MSA patients where I do just low dose injections in the neck for that bending and flexing, or in the leg for the spasming. The oral medications for dystonia could include the levodopa, the muscle relaxants, and the anticholinergics, including the amantadine as well. And then you have your other syndromes. I'll cover briefly mood disorders such as anxiety, depression, and psychosis or apathy. And you just generally apply the typical antidepressants to those cases. There's not really one that's better than another. The categories are called SSRI or SNRI drugs, which just increase different serotonin and norepinephrine transmitters in the brain, which are independent from dopamine and result in various changes in the body, including mood disorder. These drugs can also help pain too, so it's kind of a double purpose. And then you apply the proper counseling and psychiatry and support network that you would for any patient with any chronic disease here. A lot of people have pain with the muscles and the nerves or orthopedic, and we use the same antidepressants as above. We address the source of pain as best we can. There are some nerve pain agents. The best tolerated are gabapentin, pregabalin, and duloxetine. There are some topical agents and patches that could be used for pain as well. You can talk to your doctor about those, and then physical therapy can help. And sleep disorders are very broad and significant in MSA. There's often a sleep study required where you're hooked up to multiple machines at night and watched overnight to try to characterize what the problem is and to see what's going on with your breathing. If you have something called REM behavioral sleep disorder, which is where you act out your dreams, sometimes too violently, you can try melatonin. Clonazepam has also been suggested, but that has a downside for cognition and falls and alertness. So we try not to use it if we don't have to. But it is one of the major treatments. You might have some sleep apnea or other sleep disorders that need treatment. The treatment of sleep apnea is called CPAP. It's also a variant of it is called BiPAP, basically with high pressure going into the face at night on a special tubing system and machine that can open up the airway when you're having collapse. In MSA, there is more problems with the airway during sleep. The airway might collapse too much, or it might close instead of opening, and that can cause something called stridor or obstruction when you're having a gasping, like pulling of the air through the vocal cords that causes a high-pitched noise. If you hear that, then you really should get on the CPAP and BiPAP, because that's a higher risk of death from not breathing well at night. A good number of MSA patients get into trouble with sleep breathing disorders. If the stridor is bad enough, that means the vocal cords are closed too much, and you might have to bypass them with a tube, which is called a tracheostomy, and that requires special ENT evaluation and treatment. And then non-medication treatments for MSA. We'll go over each of these. Education, of course, learning what's best for you, being an advocate for yourself is the first thing. Exercise of all kinds can help. The physical, occupational, and speech therapies, altering your diet, getting counseling, thinking about palliative care, and applying any non-traditional therapies as well are the options we have here. So we want to try to, with PT and OT, reduce the spasticity and rigidity through stretching and braces and prevent contractures. there's a lot that can be done with stretching and putting the body into a better position with chairs and different splints and supports and things like that that PT can address. And then you just want to pay attention to your general medical health as well, because your outcomes are going to be worse if you don't take care of your heart, your vascular risks, meaning strokes and heart attacks, your blood sugars, your vision, your hearing, and reducing the risk of infections like pneumonia and urine tract infections, and having a good nutrition, uh, just a general healthy diet to reduce all those factors. These things will help you live longer and healthier if you pay attention to these things. Just a special note about palliative care. It is okay to start it early. People think about palliative care as something that you only do when you're in the last stages, but when you're thinking about it, all MSA treatment is palliative, meaning it's not curative, but it's just supporting the patient. So why not use the services of a formal palliative care consult early? There are palliative teams and palliative doctors out there, and they can complement what your neurologist is doing. And in some cases, it is the neurologist. We have at Rush a couple people that work with palliative care that are neurologists that do MSA treatment primarily. But talk to your doctors about getting some palliative care help, if even early is fine. Speech therapy, I'll make a special note of this because this is a frequent cause of mortality in MSA patients that is potentially treatable or modulatable, that through paying close attention to this, you want to prevent and be aware of any aspiration risks, meaning getting food in the airway or water in the airway. You want to make diet changes, oftentimes get more calories if you're losing weight from the swallowing issues. Softer foods might be required that don't get stuck in the throat. You want to change your diet through the course of the disease and make sure that it matches your swallowing ability. You might discuss considering alternative feeding methods. It's invasive, but many people do a PEG tube, which is through the stomach, and that allows you to get more calories in while you're still able to do your other functions relatively well if you can't get enough food in. You might have to reduce the meal volumes if you have constipation or slow gastric emptying. You might have to use liquid thickeners if the liquid goes down too fast. You might use some things to dry up the saliva if you have too much salivary production that blocks the airway or makes you cough too much. Drugs that locally block the anticholinergics like atropine on the tongue, or botulinum toxin injections to the salivary glands, which we do to reduce the drooling. And there's also speech communication devices that will allow you to bypass the difficult speech issues that can help translate what you're trying to say. So there's a lot of good treatments there. And then most of this has been about Parkinsonism, but there's a little bit about ataxia here, because ataxia is one of the unique features to MSA that separates it out from the other atypical Parkinson's and brain degenerative disorders. And it's kind of a short summary because there's not really a lot of drug therapy. The ataxic symptoms, the cerebellar symptoms are generally more refractory to drug modulation because they're really due more to anatomic injury and not so much due to any neurotransmitter or reversible process. So that many meds have been studied. I listed them there, but none of them have been proven to work well, except for there's two where they did some trials on patients with MSA and also other degenerative ataxias, such as SCA, which is another spinocerebellar ataxia, another type of degenerative ataxia that mimics MSA. Putting all those patients together and giving them one of these two drugs showed a slight improvement of the symptoms. Riluzole is one, that's the drug for ALS. Varenicline is another one that's used for smoking cessation. And both of those drugs showed a statistically significant improvement in the ataxia scale in these patients if they measured it over a short period of time. However, these drugs do have significant side effects that might require more monitoring, such as EKGs and liver function tests. And the individual value of them in one patient is perhaps lighter than the value than it is, in the statistical change in the group of patients. So I've presented these drugs to people, and we've tried the one or two of them occasionally, but I've personally not seen a great improvement with them. But if you wanted to be aggressive and try them to try to treat your ataxia, these are drugs you could consider trying. But most ataxia management is otherwise non-pharmacological, given the lack of effective drugs for ataxia. So And then just a last slide on a exercise. We really do promote this a lot because at least in Parkinson's, maybe not in MSA so much, there is a correlation between how much exercise you do and how long you live and the quality of the life during that time. The more exercise you do, the longer you do it, the better your survival is, the better your symptoms are overall. And so any type of exercise is good exercise, anything that causes movement. If you're not able to walk, you can still do a lot of things in the chair or in the water, for example. You try to do at least 2.5 hours a week. It doesn't sound like that much, but that equivalates to about 30 minutes, 5 days a week, or maybe 3 1 hour sessions a week. More can be better, but you want to at least hit that bottom goal of 2.5 hours a week of strenuous activity. The higher intensity you do, the better. And it's relatively safe overall as long as you take fall precautions. So you try to do a combination, if you can, of some aerobic and strength training to get your muscle mass and strength up, as well as your aerobic capacity and endurance. There's a lot of skills-based exercises like cycling, water aerobics, and rock steady boxing, which is designed for Parkinson's, but really could be applied to MSA too. And just try to involve others to work with you on that, so that you could, if you try to motivate yourself, it doesn't work as much as if you have other people motivating with you, and set some goals to just do a little bit at a time. Maybe Fitbit, say I'm going to do 3,000 steps a day, or if you can't walk much, maybe even 1,000 steps or 500 steps, but just have something that you can push yourself and say, I've accomplished something. I've done something that fights this disease, because this is really the best way outside the drugs that you can fight the disease, is to stay active and to exercise. I believe that's my last slide there, but yeah, if there's any questions, please give it to the general question bank, and we'll answer those later. Thank you.